Hello, my name is Christina Tepke, and I'm a pediatric nurse practitioner in pediatric hematology oncology at Penn State Hershey Children's Hospital. I thank you for the opportunity to present our research to you today. Today, we'll be discussing novel venous access in young infants undergoing allogeneic stem cell transplant. This project was conducted by myself along with my colleagues, Kate Lee and Terry Shapiro. Between the years 2018 to 2021, the Pediatric Stem Cell Transplant Program at Penn State Hershey Children's Hospital transplanted 7 infants for severe combined immunodeficiency, or SCID. As with many pediatric patients undergoing stem cell transplant, multi-lumen central venous access is really necessary in order to provide the appropriate supportive care with multiple simultaneous IV infusions. These IV infusions include IV chemotherapy as part of their conditioning regimen, IV immunosuppression, often IV pain medications, IV nutrition, and often antibiotics. However, because of the small size of these infants and their small central veins, placing a double lumen Broviac, which would typically be our line of choice, was not possible or safe for these infants. Therefore, there was a deficit in line spacing that we needed to overcome. In order to do this, we decided to place a single lumen Broviac as well as a single lumen saphenous PICC line in these patients. This research analysis was conducted through a retrospective chart review on these 7 patients. The outcome data that we collected was use of the central line, what IV infusions did these patients actually receive, as well as line-associated complications, including central line-associated bloodstream infections, loss of central access, and central line-associated thrombi. Looking at Table 1, we recorded the age and the weights of these patients at the time of their line placements. In terms of the average age of patients at the time of Broviac placement, was recorded about 47.4 days of age. The average age at the time of PICC line placement was 63.1 days of age. Likewise, the average size of these patients at time of Broviac placement was 4.32 kilograms and 4.97 kilograms at time of PICC line placement. The PICC lines in all of these patients were removed prior to their discharge from the hospital. So these patients went home with just a single lumen Broviac catheter for use in the outpatient setting, because often these patients will still require some IV support in the outpatient setting, such as with blood products. The median day of discharge for these patients was day plus 25, with a range of discharges between day plus 19 and day plus 44. In terms of our outcome data, looking down at graph 1, 7 out of 7 infants required their IV for blood product support, IV fluids, immunosuppression, IV antimicrobials, and IV chemotherapy. 2 out of the 7 infants did require their IV access for total parenteral nutrition in order to fully meet their nutritional needs. And 4 out of 7 of the infants did require IV pain medications. In terms of complications, we found that none of our patients experienced a line-associated thrombus. One of the patients did experience a central line-associated bloodstream infection, which cleared with appropriate antibiotic therapy. 2 of the infants did experience a loss of line access, which required the replacement of that line. In conclusion, we were able to achieve multi-lumen venous access in these 7 patients by using a single lumen Broviac catheter and a single lumen saphenous PICC line. Overall, the patients in our cohort experienced few complications, and most importantly, in those that did experience line-associated complications, the length of hospitalization was comparable to those who did not experience line-associated complications. I thank you very much for your time and for viewing our research today. If you have any additional questions, we would be happy to answer them, and please feel free to contact us at the information provided below. Thank you very much.